Okay, so let's talk about that. So we had Jacob asked about, couldn't you also hear edema? So the word edema is, as a finding itself, is not a respiratory lung sound. Okay, what would indicate edema? What would be the finding itself that would indicate that there is pulmonary edema? If you're going to go with that idea. Okay, good. Crackles. Okay, so if the option said crackles, okay, then that would apply definitely. But edema itself, that would not be like an auscultation type finding. Okay, as far as hearing it is what you're saying. And there's lots of different reasons for edema. So just because somebody has edema in their, you don't know where this edema is when you look at this question. It could be in their feet, in their ankles. It could be in their arm. You don't know where this is. So when you're reading these questions, really think about what the question's asking. The question's asking which response should the nurse anticipate. Anticipate. What would you expect for the patient to exhibit if they were having acute? Now remember we talked about that a while ago. Acute respiratory distress. Acute. Okay. So what were those findings that we talked about? Retractions. Acute. They're working hard. That's usually always a sign. They're working the increased work of breathing. And why is the tachycardia correct? What's happening there? Increased heart rate. Why? I'm going to ask you why.
To increase blood flow to the tissue so that they can have more oxygen than what the body's taking in.
Absolutely. You hit it right on target. So that's a compensatory mechanism as well. So heart rate's going to go up, respiratory rate's going to go up. Bradypnea is not correct because bradypnea would be slow respiratory rate. And with acute distress, we would see fast respiratory rate. We would see tachypnea, right? It wouldn't be until the patient basically is at the end of that and they're basically going to code on you that you would see them stop breathing. So we would anticipate a fast breathing pattern. Does that help everybody understand that and how you would work through that question? All right, let's go to another one. Let's do another practice one. So this one is just one answer. So I do want to tell you just to kind of expect this on the test this semester. Because NCLEX is doing this now, it will not always be just 4 choices to choose from when it's just a regular test question. Sometimes I will give you 5 choices to choose from. It doesn't mean it's a select all that apply unless it says it's a select all that apply. I'll give you a couple more minutes to answer this.
Just curious, can you guys see those results coming in?
We can still see them.
Yeah.
Okay.
That's okay. I'm just glad you got it working. All right. So it looks like the majority of you picked option A. Okay. All right. So can someone again tell us why they chose option A over the other options? What was your process, your thinking process? Bilateral chest expansion. All right. So why was that important, Alexandra?
Because if you're doing like fractioning, you want to make sure that they're breathing regularly and normally, and the respiratory rate was a little bit high, but they still had bilateral chest expansion. They weren't using accessory muscles. Not all of their other vital signs were increased.
Okay. All right. So Tabitha, you said all of the options could be occurring if the airway wasn't patent. So tell us more about that.
So bilateral chest expansion wouldn't be possible if that wasn't, but all the other options could be happening even if the airway wasn't patent. So it has to be option A.
Okay. Very good. All right. Great job. So both of you guys are correct. So what you want to do is you got to think about, okay, I've just suctioned this patient. And so what is the goal of suctioning? We're trying to clear the airway, right? We're trying to clear the airway, make it patent. So what tells me as a nurse that the airway is patent? Okay, there's a couple of things I need to really think about respiratory assessment wise. So one of them is listening to the lungs. Okay, and I hear bilateral breath sounds. Okay, so I can hear bilateral breath sounds, lung sounds, breath movement on both sides. Now sometimes there still might be some crackles in there, but I can hear breath sounds. Well, that's one indication that the airway is patent. Another one is if there is air movement, I'm going to have the patient's going to have bilateral chest expansion. Okay, both sides are going to be moving, right? Bilaterally. So I really want to watch for that. So while the respiratory rate is elevated, that doesn't tell me anything about patency of airway. Okay. They might still be breathing fast. Well, first of all, just suction them. So they're going to probably maybe breathe a little fast for a few more minutes after that, or they may have respiratory disease already. Okay. But that's not going to be the determining factor. So when Tabitha was talking about looking at the other options, nothing else really tells me about patency of the airway. Accessory muscle usage tells me the patient's having difficulty, right? It's a compensatory mechanism. Vital signs. Typically students always want to go for the vital sign options. I'm not sure why. But just remember, if you're going to look at a vital sign as an indicator, make sure you're understanding what those vital signs are telling you. Do these vital signs tell us anything about patency of the airway? Is it going to be a determining factor? Is it going to give me that information? Okay, so that's how you would approach that question. And again, I'm giving you these questions we're spending lots of time on these because I find that that's what students really need in that surge is to talk about, how do you go through this? How do you think about these options and make these decisions? All right, here's another one for you. Now this one says results not shared, so we'll see what happens. I may not be able to see them now. And maybe Dr. Terzilli, can you see them?
I think that when they're done, so in a few minutes, let me know when. I think I'm going to hit this submit button and everybody can see. So that's only 2 responses right now, though. So
okay, great. This one shouldn't be that difficult, so give them another 30 seconds or so. I can see it shows me how many other people, 54.
Well, just kidding. It won't be. It won't let me share the results. So.
Okay. Can you see them?
No, I can't even see them.
Okay. We found that one out by trial and error. All right. Okay. So yes, we do love technology, don't we? All right. All right. So the correct answer is B, normal acid-base balance. Okay. So I'm not sure if you chose that or not. But if you did choose B, can someone tell me why you chose B?
All the values are within the normal range.
Exactly. All right. Good job. Thanks, Rob. So again, we talked about ABGs and I know you guys had some of this content in foundations about ABG interpretation, but always look at your values, understand your values, your normal ranges. And sometimes historically, when I've given this question, people are thrown off by the PO2 as 89 because they're thinking oxygen saturation instead of arterial PaO2. So again, 80 to 100 is the normal for PaO2. Okay, so you're right. So what would happen if we had a pH that was say 7.32 and we had a CO2 of say 45. No, let's make it higher than that. Let's say 55. Okay. And then we had a bicarb of 24. What do you think's going on there? All right, good job, Sarah. Respiratory acidosis. Okay, and it's uncompensated. Very good, Tabitha. So that I want you guys to review those ABGs and those components. We have some ABG type worksheets that I'm going to be posting on Brightspace for you guys to work on before the first test. And I may even ask your clinical instructors to be working with this with you in post-conference as well. So those will be coming pretty soon, some case studies for you. Victoria, you said it was uncompensated. So how did you know it was uncompensated?
So basically, because the bicarb level was still within normal range, you can tell it's uncompensated. When it gets out of normal range, you can tell it's partially compensated.
Okay, so which way would it go? So if the bicarb was trying to compensate for this respiratory acidosis, what would the bicarb be doing? Would it go up or would it go down? Anybody can answer that. Okay, it would go up. Very good. Now, why is that? What's it trying to do? Neutralize, right? Add base. So again, it's just understanding acids and bases. So as the bicarb goes up, it's adding more base to even out that acid, to decrease the acid. And so what would determine if it's fully compensated? What would we see? What component of the ABG would we see a change in? Very good. Okay, Tabitha, pH would be in normal range. Very good. All right, great job. Awesome. All right, so now we're going to move on to tracheostomy, which we talked about a little bit we were talking about sectioning a while ago. We haven't really talked about tracheostomy too much. So I want you to think about main concepts from this content from the Panopto. If you had to list 3 main concepts regarding care of a patient with a tracheostomy, what would be those big concepts to understand? Okay, skin care integrity. All right, so these are good. Infection, skin care integrity is really good, but I'm looking for the top one right now. Patent airway. Okay, all right. So patent airway would be like the number one because, if a patient has a tracheostomy, that is their only airway, right? Okay. So that has to remain patent for them to be able to have an airway. Okay, it cannot get clogged. Okay, with mucus. So I'm talk about that in just a second. What is another concept in keeping that tracheostomy patent so it doesn't get clogged? What's a big concept so that to prevent that? Suctioning. Okay. There's another one as far as how we deliver that oxygen. Humidity. Very good. I saw that. Humidity. Okay, great. So tell me, Mariah, why is humidification so important for this patient?
Can you hear me?
I can, yes.
Perfect. Okay, so when you're delivering oxygen, you just want to make sure that you're not drying out that stoma. So you want to add humidification to keep that moist.
Exactly, and that's going to decrease those mucus plugs from happening and clogging up that little tracheostomy tube. So we've got patent airway, humidification, oxygenation, and then we've got everything else that is coming along with that: integrity, skin integrity, preventing infection, keeping that nice and dry around the stoma. Not we want to make sure we get that humidification, but around the stoma itself, we're trying to keep it as dry as possible so we maintain that skin integrity. Good job. So if you look at this picture here on the slide, on this PowerPoint slide, I talked about this in the Panopto. This just shows you the different components of the trach itself. So does anyone remember what this one on the very bottom is, this little long tube here? Obturator, very good. Okay, and why is that? What's an obturator used for? Why do we need that? What does it do? Somebody's saying recannulate. So Sadie, can you tell us more about that? Recannulate.
Basically, whenever the trach is pulled out or whatever happens to the trach, you put it in to help you put the trach back in, a new one.
Very good, awesome. So if you think about it, if a patient has a fresh trach put in, this is their airway here. We just created this new airway. If for some reason it gets dislodged and they cough it out, so that's why we always want to make sure that it's secure, either with trach ties. A lot of times when they first put these in, they suture those in for several days. But if for some reason it would become dislodged, it's a newly created opening that can close off very quickly because there's lots of edema and swelling because it's a new surgical opening that's been created. So that trach, that stoma could seal off very quickly and occlude, and they would no longer have that airway. So that obturator is there to help facilitate putting that trach back in. It is more of a stiff piece of material to help guide it back in. So this middle portion, this middle tube, is what's called the inner cannula. And this is the piece that is either disposed with when you're doing trach care, and it's a disposable inner cannula and you put a new one in, or it's cleaned, like you're going to practice in your skills lab when you have a first skills lab. So that obturator actually goes in the new trach, basically, when you put the trach back in, but that inner cannula is inside of this piece, and that obturator guides it back in, okay? Now, what is this little thing off to the side here that looks kind of weird? It's attached to that inner cannula. What is that? Anybody know?
Is that to inflate the cuff?
Very good. That is basically that's the cuff, the trach cuff, and so a syringe, like a 3 milliliter syringe, attaches to the end of this here, and then basically air is put in there to inflate the cuff to keep it in place. Now, usually you see this is with in adults with new trachs, okay? But if they have a trach that they go home with long term, they usually will replace this with a non-cuffed trach if it's going to be a long-term tracheostomy. Why would that be? Why do you think that cuff couldn't stay there forever? What could happen with that cuff? And you think about when it's inflated there. Very good, Abigail. Awesome. Okay, so Abigail said necrosis of the trachea. So yeah, it could cause too much pressure on that trachea tissue and cause necrosis. So that's usually, and we see this in the hospital in those acute type settings, but later on, if it's a long-term trach, they will replace it and it will not be cuffed. I'm not a pediatric nurse, but I know in babies, they usually don't have cuffs either. I'm pretty sure of that. So, so you'll hear about that in pediatrics. But for adults with new trachs, they usually you'll see these cuffs used. Respiratory therapy will help nursing with assessing that cuff pressure to make sure it's not too great and not causing too much pressure on that trachea tissue. So that's something that we collaborate with respiratory therapy on, definitely. You guys are doing awesome. All right, so here's a question for you. You guys are doing a great job in participating today. I really am impressed. Thank you so much. This helps tremendously and to have your participation. Okay. All right. So it looks like a fair amount of people, 73%, chose option A. And we had a few people choose the last option. So let's look at this question. All right. So basically what you have, you want to start with the scenario itself. Okay. So you have a patient with a new tracheostomy. Okay. And they're getting their humidified oxygen. It gives you a percentage there. And it's being delivered via trach collar. That's how patients receive their oxygen, via trach. And the patient is having thick yellow mucus. All right. So that's a concern because why are we worried about that thick yellow mucus? Why am I worried about that in a new trach patient? Okay, clogged airway. That's going to be good, Courtney. That's going to be the main thing I'm worried about. Remember we talked about those main concepts? Think when you're going through this, think back to those main concepts. With a new trach patient, I am most worried about. I am worried about infection. Yes, I am. But if the patient doesn't have a patent airway, that's the main thing. That's because they're not going to be breathing. They can't breathe. So I'm most worried about that patent airway, obstruction of that trach with that thick yellow mucus. So we got to get that cleared out. Okay. So the question is asking you which of the following is most appropriate for this patient, and what you need to think about is the scenario that it's giving you and what that main concept is. Okay. So a lot of you all chose A, and then we had some people choose D. So tell me what you were thinking about that and why you chose those answers.
I chose E or whatever because I remember from foundations, from our skills modules, it said that like when you have thick mucus or whatever in the trach, it's harder to suction. And I know like when you're drinking fluids, it's going to help kind of thin those out and make it easier to suction. So I felt like even though suctioning would be good, it would be more difficult with the thick mucus. So having them drink more fluids would help.
Okay. So this is you're right. Your rationale behind the fluids is correct, Dylan. Absolutely is correct, your rationale. But what makes this is not the best answer for this question because this patient is a new trach patient. So this patient, they may not be able to be drinking fluids yet. Okay, so we don't know that yet for a fresh tracheostomy. Okay, now we may have IV fluids going, which we most definitely would for this patient post-op tracheostomy to help thin out fluids, but maybe not drinking fluids at this point in time. Okay, a lot of these patients have to have enteral tube feedings to prevent aspiration and those types of things in the beginning. Okay, so that's just something I think that you guys will understand the more you read about the content and go through it. Why A is not the correct answer? So I'll go ahead and just tell you. So B is the correct answer. Why is A not the best option for this patient? It says set a schedule to suction the trach every 2 hours. All right, Abigail, good. Okay, so Abigail said in the chat, you don't want to suction on a schedule if they don't need it. Okay, do you think it's possible that the patient might need to be suctioned more frequently than every 2 hours to maintain an airway, the trach airway? Absolutely, right. So in the penalto I talked about, sometimes these patients, depending upon the amount of secretions they have, you might be suctioning every 30 minutes to an hour. The main concept is that we have to make sure that airway is patent. Okay, so that's how you would work through those options. Does that make sense to everybody? Okay. All right, so here's another one for you. Okay, just another couple seconds here. Remember, think about big concepts. All right. So it looks like the majority of people chose A, suction the patient prior to performing tracheostomy care. So can somebody tell me why they chose that? Somebody new. Let's hear from somebody we haven't heard from yet. Oh, come on, be brave. Okay, Alex.
I can discuss my rationale behind it. I felt like for option D, at least when I've been in the hospital, you apply sterile gloves when cleaning the inner cannula for like infection risk. And then for option E, 10 liters per minute could be like really extreme for some patients, so that's not really something that you'd want to do off the bat. And when you're performing tracheostomy care, you wouldn't want to perform it if the airway isn't patent. So by suctioning it prior to performing that care, you can ensure that the patient's receiving the proper care.
Okay, thanks, Taylor. So good. So what Taylor did is she went through the different options to see what was wrong with it and why it wasn't the best option. And so that's always a really good way to approach these questions. So you're correct in that when cleaning the inner cannula, that's one of the most critical pieces to be sterile with because that's inside the patient, right? So it has to be, love it. It has to be, sterile gloves when you are handling that inner cannula. Most definitely, it's the most important part there with maintaining sterility. Non-sterile gloves would be absolutely not correct. E, that last option, E, take a look at that again. What's wrong with that? We talked about the 10 liters, but what else is wrong with that for this patient? Is nasal cannula going to do anything for a trach patient? Are we going to put nasal oxygen in their nose? Their stoma's down here. Are they breathing through their nose? No. Okay. So again, look for those things that are obvious. This can't be right. This doesn't apply. Okay. So that's something you want to think about. The patient with a trach they're not going to tolerate wearing a mask. Okay. That's probably not going to work as well. And we have to have access to the stoma, so that, we're wearing the mask, not the patient. And then B is not the correct answer because why? What is the main concept here? Why is B not the correct answer? Okay, Abigail, good. You want to put the new ties on first. Why is that? Always ask yourself why. Exactly. Very good. Absolutely. You guys are getting it. Nice job. So we remember that concept that we don't want to lose that trach. We want to keep it secure. We don't want it to dislodge because we got to maintain that airway. Same purpose. We want to make sure everything is secured. If we take off those old ties first, then the trach's just kind of wobbling in the wind if you want to think about it. And then that patient could cough that out. Now we'll just go ahead and give you a heads up so you're not confused. When you watch the HESI video on this, it does talk about a nurse taking those new ties off. Okay, it does say that. I know. I've looked at it. Okay, it says taking those new ties off first. But what you'll notice is they have two people doing trach care, and the one person is stabilizing the trach while the new ties are being put on. So they remove the old ties and put the new ties on. So that one person's stabilizing the trach, and that's why that could be done that way. However, and you're going to say I'm contradicting myself, but I'm absolutely giving you the correct answer and steering you towards NCLEX. For NCLEX purposes, you never ever take off those old trach ties until you've put the new ones on, okay, to secure the trach. And again, the reason for that is the rationale that you don't want to lose that trach. And they're testing you in a circumstance that you would be by yourself, you're not with a second person, those types of decision-making things that you're trying to work through. So I just want to go ahead and mention that because you're going to watch the video and you're going to say, but that's not what we talked about in class. And that's the reason why, is it's two people that are actually working with that trach. Okay, so just so you see that. So suctioning prior to trach care is really important because we want to make sure that we clear all that mucus out. Anytime we touch that trach, we do anything with that trach, we manipulate it, the patient's going to be coughing a lot. So you can imagine you're going to go in and do trach care, what's going to happen? They start coughing and you hadn't suctioned them. What's going to happen when you start trying to manipulate that and change all that out? What's going to happen without that mucus? What do you think? Is it going to be going all over the place? Yeah, it's going to be going all over the place. Yeah, it's going to be a big mess, and you're going to defeat the whole reason why you're doing the trach care and getting everything cleaned up. So let's go ahead and suction it, get that airway nice and patent, and clear those secretions, give the patient time to recover and relax and catch their breath, and then do the trach care. So that's normally how we would go about it. All right, so thoracotomy. We're getting towards the end of class time here. So what I'll do is I will pick up from this slide the next time we meet, and we'll continue going over this content. And we'll finish this one slide before we stop the meeting, okay? The answer to that one was A. The correct answer was A on that last question. Suction the patient prior to performing trach care, okay? All right, so thoracotomy. Who gets a thoracotomy? When is it done? When is it needed? Why is it performed? What is a thoracotomy? Okay, it could be used to diagnose a disease, obtain a biopsy. Okay, so a thoracotomy, you're right, Courtney, is an opening in the thoracic cavity. Okay, a lot of times it's to remove a tumor, to remove a lung, possibly. It could be to put in a chest tube, those types of different things. All kinds of reasons to enter that chest, for sure. Most of the time when you're dealing with these patients in the hospital, a lot of times it's going to be for removal of a cancer. Okay, that type of thing, either a lobe or maybe even an entire lung. So you will see that done quite frequently. So what are the high priority assessments when you're caring for this patient? Let's say they just had their lung removed. What are you going to do when you walk in that room? We definitely want to turn the patient, but is that my first priority? I know you guys talked about positioning and all that in foundations, but we're moving on to some other things here. Okay, breath sounds. Okay, great job, good job. All right, we're focusing on airway, right? Airway. So what do I need to do to make sure this patient has a patent airway? That's all the things we've already talked about. Assessment, okay? Inspection. What does this patient look like when I walk into the room? Are they in distress? What do their breath sounds sound like? If they have a chest tube put in, is that chest tube connected the correct way? And if not, I talked a lot about that. And we'll talk more about the chest tubes next week in class. Vital signs, chest movement, pain level. What does their depth of their respirations look like? If they're breathing really shallow, maybe they're in a lot of pain. And so they're not breathing shallow, they're not breathing deep enough, and they could have atelectasis, right? And they could start to get into some problems with their ABGs or oxygenation status. So those are all really, really high priority things. Yes, we do want to turn the patient. Yes, we do want to assess for the wound and the site. But first and foremost, I have to assess to make sure my patient, their respiratory status is where it needs to be. Okay, and that's what you need to be thinking about, high priority things. All right, so I think we'll stop here because it's 11:32. I'm gonna give you time to get lunch, rest a little bit, take a little walk with your dog or whatever before you get online for patho. And I know, Dr. Terzilli, are you teaching patho again this semester? I'm not sure if she is or not, but if she is, she needs a break too before patho starts. Okay, go take a break. All right, so you guys did a great job today. I'm gonna stop the recording and I will see you guys next week, and let me know if you have any questions, okay? And you are most welcome. You did a wonderful job. You should feel very proud of yourselves.